Yes, you can start.
A very good evening to one and all. Today's topic is pulmonary rehab and palliative care. Myself, Dr. Shruti Shah, and my colleague, Dr. Rasika will be taking the respiratory masterclass. Next. So what is pulmonary rehabilitation? Pulmonary rehabilitation is an intervention which includes education, exercise training to bring about a behavioral change, which indeed improves the physical and psychological condition of the people living with chronic respiratory diseases. Next. Why do we do pulmonary rehabilitation in palliative care? So palliative care is a specialized medical care given for people living with serious chronic respiratory diseases like ILDs, COPDs, asthma, bronchiectasis, etc. It helps improving the quality of life of the patient as well as the family. And the benefits of pulmonary rehabilitation in palliative care will be to provide relief of symptoms to the patients. It will give us a better patient and family understanding of what to expect. It also helps the patient and the family to know about the preparation of future. And it will also reduce the hospitalization incidences, or else the patient is more comfortable to deal with crisis. Next. What does PR include? So generally, pulmonary rehabilitation, or why PR? So patients having these different diseases like COPDs, asthma, bronchiectasis, respiratory diseases like restrictive diseases, ILDs, generally have difficulties in breathing. They have breathlessness, they have coughing. So in pulmonary rehabilitation, we do patient education and counseling. We give them dyspnea relieving positions. Breathing exercises are done. Airway clearance techniques are taught. Aerobic training is done. Strength training is done. Flexibility training. Posture correction is done. Core strengthening also is done. Next. What do you mean by patient education in pulmonary rehabilitation? So when a patient with a ILD walks to us, he is not aware about the condition or his diagnosis. He doesn't know what to expect in future, what will happen with him, or what are his symptoms, or what would be the ongoing course of the disease. So if a patient visits us, at the first visit, we counsel the patient about his condition. Generally, all the lung patients have breathlessness. So dyspnea relieving techniques are done to reduce the breathlessness. In dyspnea relieving techniques, the main goal is to facilitate the diaphragm, which is the primary muscle of respiration, and to reduce the accessory muscle load. So generally in chronic respiratory diseases, because of breathlessness, the patient uses more of his accessory muscles in breathing. So by doing dyspnea relieving techniques, the patient facilitates the diaphragm more, and hence the breathlessness reduces. Breathlessness, if it is more, the patient will try and avoid doing any activities, so which in turn will again increase the breathlessness. So it's a vicious cycle. So we need to break it in some way so that the breathlessness goes down. So in the picture, you can see that the high sideline position is given to reduce breathlessness. Forward lean sitting without pillows can be done. Forward lean sitting with pillows. Normally comfortable upright sitting on chair. Forearm support to assist breathing using a trolley. In the sixth picture, we can see that the forward lean standing position is given. And in the seventh one, standing with back support is generally done. A number of relaxation techniques are also used to reduce the anxiety which patients generally face in these conditions. So relaxation techniques involve Jacobson's techniques, Laura Michelle techniques. A number of techniques can be done. Even yoga asanas like Shavasana can be done to calm down the patient who has anxiety. Energy conservation techniques. So energy conservation generally means to use the ample available energy to the patient wisely. So by doing this, he will conserve the energy and he will use it only for the activity he wants to do and which is needed for his daily care. Pacing. Pacing means that the patient will prioritize, plan, and prepare for the future activities in such a way that he does the same task, but in three different steps. So first he used to just do it in one go, but now since because of the increased breathlessness, he will have to stop, take some pause, and then continue the activity. Next. Breathing exercises. So a breathing exercises involve different parts of the lungs. Hence, they enhance the breathing capacity of the patients. Apical breathing exercises are done. Lateral costal breathing exercises given to improve the expansion of the lower part of the lungs. In apical breathing technique, we focus on the upper part of the lungs. Thoracic expansion exercises are given in which the patient uses hand movements simultaneously with breathing. Diaphragmatic breathing exercises is an important part of the treatment plan because he focuses on the primary muscles of inspiration. And by doing that, in turn, the work of breathing is reduced. Inspiratory holds are given to the patient. Inspiratory holds in patients with ILDs, since it's a restrictive type of a disease, inspiratory holds will facilitate more activity of the diaphragm and hence better capacity. Expiratory holds are more focused in patients with COPDs, asthmas, bronchiectasis, etc. Next. Airway clearance techniques are also given in patients who have a lot of secretions. Chest percussions and vibrations are done by the physiotherapist. And positive end expiratory pressure devices, which involve a cappella, aerobica, flutter, are given to the patient. Next.
Yeah, from here I will continue. So my name is Dr. Rasika. I'm the pulmonary physiotherapist in Bhatia Hospital. So when we talk about pulmonary rehab, I would like to ask how much do you all know about the rehab? Anyone? Am I audible?
You can talk, please. Anybody would like to answer that? Yes, Subbalakshmi. Please unmute and talk. Hello, Dr. Subbalakshmi. Yeah, there you go.
I came to know about this pulmonary rehabilitation and its importance only during the COVID pandemic. And I realized the importance and the dramatic impact it had on patients who would have otherwise been very desperate, despondent, and dejected with their illness. But the actual details of rehab is something that I'm going to learn now in this session.
Okay. So basically what we do in
Anybody else wants to share? But that was a very good, thank you for that. And it's nice to know that it is one of the topics that was suggested by Dr. Sridevi to include. And we have these young physiotherapists who are very enthusiastic with their patients.
Okay, so I'll continue now. So basically what we do in pulmonary rehab, when a patient enters our OPD settings, first, as Dr. Shruti said, we counsel the patient, we teach them breathing exercises. The next part of it is, so there are three components. First is aerobic training, then is resistance training, then is thoracic mobility, and the fourth one is posture correction. So now first, most of the people think, why aerobic training? Why do we need this? We are not going to go to the gym. We are just going to do our regular activity. All that is right. But why aerobic training is needed is it increases your VO2 max. It increases it conditions the muscles of ambulation, which will in turn reduce your breathlessness. Then it increases physical activity, which is associated with reduction in breathlessness and fatigue. Okay. And it also lowers the ventilatory demands of the patient. So what do we do in aerobic training? Initially, it was like we would used to progress gradually, like from a lower intensity exercise to a higher intensity exercise. But then they notice that as the patient progresses to a higher intensity exercise, the breathlessness increases. So according to the recent research, according to AACVPR, which is American Association of Cardiovascular and Respiratory Physiotherapy, and pulmonary rehabilitation, they have started something which is called as interval training. Now, what we do in interval training is high intensity exercises. When you achieve that point where your patient can exercise in a higher intensity, we interpret, yeah, give rest periods to the patient between two high intensity exercises. So this can be done by giving an high intensity exercises, then giving a patient a rest pause, and then again continuing with the high intensity exercise. Or we start with a high intensity exercise, instead of a rest pause, we give them a lower intensity exercise, and then again a high intensity exercise. The advantage is that the symptom score of the patient has reduced because of interval training. So how do we function with this? Like, we follow the FIT principle, which is frequency, intensity, time, and type of exercise. So according to the FIT principle, the frequency of aerobic training should be 3 to 5 days per week. The intensity should be like the patient should perceive the exertion as 12 to 14 on a 6 to 20 box scale. Does anyone know what a box scale is?
No.
No? Okay, so a box scale is the scale which it is a subjective scale. So it can be different for me, it can be different for Shruti, it can be different for another patient. So it is how you perceive your exertion. So there are two scales. The first one is the original one, and the second one is the modified one. The modified one is from 6 to 20. So if you Google it, you will get the scale. It is from 6 to 20. So 6 is like very light exertion. So it is subjective. It is how your patient perceives it. The time of exercise is 20 to 60 minutes. And what we do in aerobic exercises, walking, cycling, like these are all the aerobic exercises we practice here, like walking, cycling, treadmill, spot marching, jogging, and stepping. Okay. Clear till now? Any questions? Yeah, the modified box scale. Hello, any questions or can we continue?
Please continue. I've sent the link of modified box scale on the chat. Please
Okay.
continue. And all of you, any doubts or clarifications, keep sending on the chat. I will make a note and ask them in the end, or I will try and answer via chat.
Okay.
Yeah, go on.
Can we continue? Can we go to the next slide? Okay. Now resistance training and strength training. So I would like to ask why do you think this is included in pulmonary rehab, like strength training or resistance training? Anyone?
You can think of the breathing, thinking, functioning model. Remember, we spoke about that in patients with breathlessness. Because these patients are not very mobile, they are deconditioned, they lose their muscle mass because of not using it, and therefore you need to retrain the muscles, and therefore the muscles need strengthening. Remember that breathing, thinking, functioning model, that is the reason for breathlessness in patients with advanced lung diseases. Over to you.
Okay, so why do we include resistance training is, see, now it's a vicious cycle, right? Breathlessness. So once the patient is breathless, automatically the activities reduce. All the activities will reduce automatically. Once the activity reduces, life becomes sedentary. Once sedentary lifestyle is in, your muscles will start getting deconditioned. So as it progresses, initially you won't be able to do only the activities which are very exerting, but if you continue with that, you will not be, the patient will not be able to do even the simplest activity, because gradually the muscle mass is lost. So that is why we are just breaking this cycle by including strength training. Plus the like the advantage, second advantage which we get is the patient remains mobile, and the ventilatory requirement is also very less in resistance training. Okay, so as we include resistance training in the program, even the breathlessness reduces. Okay, so and other thing is your upper limb muscles, mainly your upper limb muscles are also your accessory muscles for respiration, right? So we are strengthening your respiratory muscles also. Till now, am I clear? Is it okay?
Yeah, please go on.
Yeah. So even for this, we follow the FIT principle. So according to the FIT principle, resistance training should be done 2 to 3 times a week. The intensity should be 60 to 70% of 1 RM. And time is 8 to 12 repetitions for 3 sets. And you can include weight cuffs, dumbbells, therabands, cross trainers, body weights. These are all things which are done in the rehab. It can be done at home also by simply using 1 liter bottles, or simply sandbags will also do. Okay, clear? Any questions? Okay. So next slide. So now thoracic mobility exercises. Anyone can answer why is this included in the rehab? Anyone?
To help in breathing, because the thoracic movement will help in the breathing.
Sorry.
To assist in breathing, because the thoracic movement exercise are going to assist in.
Yeah. So if you observe a posture of a person who has a respiratory condition for a longer period of time, so can you all tell me how the posture of a patient looks like who has been suffering from a respiratory condition for a longer period of time?
Leaning forward.
Yeah, right.
Protracted shoulders.
Protracted shoulders. Then if you observe, there is increased thoracic kyphosis, and also there is increase in the AP diameter of the chest. So because this mechanics of your posture has also changed, it will also contribute to the increase in the work of breathing, right? Yeah. So because it increases the work of breathing, we are also focusing on exercises. So these are a few pictures which are showing your thoracic mobility exercises. Okay. So first, like we are just telling the patient to flex his shoulders anteriorly. What will this do is even flex your, like even extend your spine, right? Can you see in this picture? So we tell the patient to breathe in through his nose, simultaneously taking his hands up, and breathe out, simultaneously taking the hands down. Okay, this will basically stretch all your intercostal muscles. Agreed? Hello?
Yeah, everybody is
Yeah.
muted, so you won't
Yeah.
hear a
Okay.
response. If there's
Okay.
anything, they will put on the chat.
Okay. So till now we are clear. So for this also we follow the FIT principle. So these exercises are done 2 to 3 days per week, and it is intensity is till the point of slight discomfort. So whenever you're doing this exercise or you're stretching your pectoral muscles, we stretch it till the patient feels a slight discomfort. And these are done for 30 seconds each, 10 times. And the type is stretching. Like we do stretching and thoracic mobility. Okay. So can we change next? Posture correction. Again, same to decrease the work of breathing. So in posture corrections, we do cat and camel exercises, shoulder retractions, TNY stretches. So TNY stretches are mostly for your shoulder joints. Okay.
What
Next.
is CNY stretches?
So basically, we are stretching the shoulder muscles, shoulder and the scapular muscles. So basically, we tell the patient to lie on the abdomen with his arms extended outwards in the shape of a T. So you just have to raise your shoulders behind. Okay. And again, the same thing in Y. So we
Diagonal.
we just do it diagonal and stretch. So this, in short, is strengthening your scapular muscles also and stretching your pectorals also. Okay. Next. So now the main thing, in advanced care, how will pulmonary rehab help? So aim is we are
1 minute,
preventing.
Rasika,
Yeah.
1 minute. There was a
Yeah.
question here.
Yeah.
Yes.
Before you go ahead,
Yeah.
they want to know the duration of each session, how each of these 4 parts, how are you distributing the time? Do you do all 4 every time? What is the
Yeah.
total duration of pulmonary rehab?
So pulmonary rehab goes on in phases. So initially it is phase 1, which is done in the hospital. So in the hospital, we focus only on breathing exercises and basic mobility. Phase 2 is the immediate phase, which is done in the home by the patient. In that also they focus on breathing exercise and basic mobility exercises. Phase 3, which is done in our OPD, it is generally we do 12 sessions alternate days, because we cannot do pulmonary rehab every day. It is done alternate days, because according to AACVPR, 24 hours rest should be there in between 2 sessions. So one day is aerobic exercise, one day is resistance training. Each session goes almost for 40 to 45 minutes. Yeah. And it goes, the program, the phase 3 is in our OPD, so it goes almost for a month. And phase 4 is the maintenance phase, so that we after the session is done, like after our phase 3 is done, we provide a report to the patient and we tell them how they are supposed to maintain this. So we give them activities which they can do at home and they can manage by themselves. So basic, our aim in pulmonary rehabilitation is independence and not to keep patient dependent on us. So whatever we teach them in phase 3 and phase 4, they have to continue that. So after they finish our phase 3, we give them a program which they are supposed to do at home. So here it is 12 sessions. In India, we do 12 sessions.
Do you have a follow-up session also, or how do you keep check on them?
Yeah, we have a follow-up. So after every month, the patient has to come to us, or he can he can give us his feedback on the telephone also. So we add.
During the pulmonary rehab session, 40-45 minutes, do the patients have any other interventions like psychology, nutrition,
Yeah.
or anything else? So what else comprises in pulmonary rehab?
Yeah. So there is there are 2 main things, like psychologist and the diet part. So that is taken care by we have a psychologist in our setup. So psychologist and diet, they also have their different sessions for that.
Anybody has any questions, or they can go on, because there was a question on how much time is resistance exercises done.
Ma'am, I
Shruti,
had
we
a
can't
doubt.
hear you.
I had, now am I clear, ma'am?
Yeah.
Am I clear?
Yeah, yeah.
Yes, yes, you can speak.
Audible?
Yeah, yeah.
So I heard this pulmonary rehabilitation exercises are not easily available everywhere. And we as doctors, I mean, not trained and we don't have much knowledge as how to, go over the session. So is there any particular format that on day one you do these? I mean, can you provide us that? Because the normal physiotherapists, they don't know this pulmonary rehabilitation.
Actually,
And I don't think so.
Yeah, actually the problem is that with this thing,
We cannot hear you well.
yeah, even I cannot. Hello? Can you all hear us?
Yes.
Yeah, so in pulmonary rehab also, whenever we are programming these sessions, it is patient tailored. Like, it is not same for each and everyone. There are multiple factors which we have to keep in mind. First is the condition of the patient and the age of the patient. These two are major factors. So whenever we provide this sessions, we have something called as a Carbonin's formula, if you all know about it.
You have to
We are
explain.
not aware of.
You'll have to explain.
Yeah. So according to we design our programs according to the Carbonin's formula. So whenever, so for example, when we are doing aerobic training, so how will we decide the intensity of the program? So once we know, okay, a patient at rest is telling that he's feeling this level of exertion. Even at rest, he is not feeling completely, is not at rest. So according to that, we uh, we decide, okay, like if a patient is an elderly, suppose, so we'll initially start with a slow intensity program, that is 30 to 50% of his maximum heart rate. So now what is maximum heart rate? So you all can calculate even your maximum heart rate by 220 minus your age. So whatever your age, suppose you're 40, so 220 minus 40, whatever will be the answer, is your maximum heart rate. Understood? So now we'll calculate your target heart rate. So target heart rate is maximum heart rate minus your resting heart rate into the intensity. Now 30% equals to 0.3%, 0.3. So into 0.3, the answer plus your resting heart rate. So that will give me one value. This is my lowest point. Now again, the same thing I'll do with 50%. So that will give me a little higher value. So this range is my range for the patient. And so whenever he exercises, I have to make sure that he reaches the lowest point every time. And then, but he should not exceed the highest point. And got it?
For example, a patient with a cardiac mortality or morbidity, like suppose he has just undergone recently CABG, so he already has a hypertension, so his heart rate should not exceed 100. So we see to it that in rehab during any of the exercises he doesn't exceed this limit. So from low intensity program, our goal will be to reach at least a medium intensity.
So we even progress with the intensity. So initially you cannot start directly on a higher intensity. You have to start with the lower intensity.
Now,
But-
since your heart rate is your target, there's a question: what if the patient is on a beta blocker? What else point can you use to assess?
See, if the patient is on a beta blocker, so we generally keep it on a lower side. So if we know that the patient is on a beta blocker, we will ideally start, even if he is a young patient, we'll start with a lower intensity, that is 30 to 50%.
Okay,
And there would be other signs like he would have fatigue or muscle
that's
pain.
what I'm saying.
Yeah,
What else
so,
will you assess?
so we would monitor the other
We
signs.
will monitor. So mainly
saturation.
rehab, we monitor the vitals first, vitals and the box scale.
Okay.
So even if you see the AACVPR guidelines, so the patient should feel exertion between 12 to 14. If he exceeds 14, then we have to lower down our program or give him rest.
You can also find talk test on Google. It can also help you. So if a patient can comfortably say 1 to 2 words during while doing exercises, that means he is okay. He is at a lower intensity program. If he can speak 2-3 sentences, he's doing better. And if he can also sing, that means he's doing it at a higher intensity program. So that can give you a subjective idea.
And the most used test here, like we do the 6-minute walk test. So why a 6-minute walk test? Is because walking is a thing, like it's a basic, it's a necessity. And it is a sub-maximal level activity. So before starting the rehab, we do the 6-minute walk test. I guess 6-minute, everyone is very familiar with.
They have now become familiar with it because of this
COVID pandemic.
palliative course. So yes, 6-minute walk test is what all of you will also know post-COVID, which is what we used to say for happy hypoxics, because COVID used to affect the desaturation, and we used to tell patients to monitor oxygen during walking. So that's a very significant and sensitive tool to say how advanced the illness is, and therefore also help physiotherapists recommend oxygen to use for exercises and not subject the patients. For example, when we did teleconsulting and telephysiotherapy, it was very important to emphasize that patients used oxygen during physiotherapy when they desaturated in the 6-minute walk test. Now, 1 minute, there is also another question here. For a palliative care center community which doesn't even have a physiotherapist trained in, but has a physiotherapist, but who does physio, say like for stroke, what are the basic exercises that can be started by them provided in the center? Yeah, so, it's a very important point, because we do not have physiotherapists in any center. So simple things, if a person is trained in basic physiotherapy, he or she is not going to take much time to understand what the chest physiotherapists do. Yes, it comes with practice and the expertise comes with practice. But again, I can extend that if you have a physiotherapist, I will request the Bhatia Physiotherapy department to see if you can have a training session for them online, so that they can pick up the training sessions. And it's simple things. You don't even need to have fancy equipment. Even if you have no treadmill, no cycle, walking also is an important thing.
Yeah.
How they give graded exercises, simple rubber bands for resistance, breathing techniques. These are things that can be taught. And the point is that they are such small investments for really good results for the patient's quality of life. What happens is that the patient actually comes back and says, today I can go to the toilet on my own, or I can go to the dinner table on my own, or I went down to the garden and sat. These things are milestones for the patient and really focuses on the quality of life. So I think if you all can identify a group from different parts of the country, like how you all have logged in, 6 or 7 interested physiotherapists, we are happy to train them with the permission of Bhatia Hospital 1. Or Cipla Foundation has also started some free physiotherapy centers across the country for those who cannot afford to pay for physiotherapy. So any information you all need on this, please connect with me. I will pass on the information, but these are simple things that can be trained. And there are more, we need to discuss with the cardiologist. I think nowadays beta blockers are principally used for HR in coronary artery disease. Yes, that is a good point, Dr. Rajeshri. An established pulmonary rehab center is a must. Can palliative care physicians deliver rehab? Only if you're trained, ma'am. Otherwise, it's not easy. And I think it really helps us that we have a good department backing, because a lot of things happen. It's not just the exercises. Sometimes, like you saw in the picture, there are 3-4 more patients. When there are 3-4 more patients, they kind of like a very healthy competition. If he can do, I can also should try to do. So there's an encouragement in the class. Second thing is the counselor input, which also helps the patient. Third thing is also the dietitian. So overall, it's a social interaction for the patient. Plus, they learn to do more and they get more independent. So it is something which is more holistic, just like palliative care. And I think it's very important. If you can get us a group of patients, a group of physiotherapists who are interested, I'm sure I can request Bhatia Hospital. These young girls are very enthusiastic and we can really train them. So that is something that you all can get in touch with us. Any more questions? Is there like a concise module handbook? Is yes.
Actually, the first phase 1, like you will have to refer our books, but phase 2, like whatever we do in the OPD settings, there is an online copy available of ASCVPR. So it is for both pulmonary rehab also and cardiac rehab also.
Can you
So,
please share the link?
Now, actually, ma'am, I don't have it now, but I can.
No, but can you share the link?
Yeah, we can.
We'll definitely.
We'll
Tomorrow,
definitely
I will
share.
send it to them.
Yeah, no problem. We'll
Yeah.
share. Yeah.
And it's got videos?
No, ma'am, it's a book. It's a proper
Okay.
book.
Okay, fine. Is there some YouTube videos on pulmonary rehab that is
No.
reliable?
No, ma'am. No.
Okay.
Okay. So now what, ma'am, should we continue?
Yes, yes.
Okay, so now what will rehab do in an advanced care? So first, the aim would be prevent deterioration in physical and psychological status. So whatever we have achieved, our goal is maintenance. And the second important thing is maximum independence in their activities of daily living. As ma'am said, that going to washroom alone or going to the garden are like milestones. So we have to maximize the independence in that. So what do we do in physiotherapy management is breathing retraining, teaching relaxation techniques, activity pacing, assistance with mobilizations, provision of gated and function directed activities. So if you see, most of these patients are very anxious. They're anxious, sad, lonely. So breathing, relaxation technique, activity pacing is very important for them. Basically doing everything on their own. I guess for most of the patients, it is very important. So this is what we do in advanced care. We focus more on functional activities. Like to give example, like a patient who is having ILD. So what happens in ILD? Anyone? What happens in ILD?
It's fibrosis of the lungs, right?
Yeah,
Yes.
So fibrosis happens, diffusion time increases, right? So what we tell for such patients who has an advanced ILD, what we suggest is them for like function, whatever activity which requires maximum energy should be done in the morning. Yeah, right, because throughout the night they have slept, they have that energy. Okay, so we tell them ki whatever requires maximum energy should be done in the first part of the day, and whichever activities require a lot of time or take a lot of time should be done throughout the day with pacing. So this is how we try and incorporate the physiotherapy in their daily living. So in advanced care, we focus mainly on ADLs, that is activities of daily living. Okay, can we change? So this is one thing which we have just included, which is of our own patient, but we cannot reveal their name. So this Mr. XYZ was diagnosed with ILD, works in OPD for pulmonary rehab on supplemental oxygen during rehab. So what will we do for this patient? So that is in the rehab phase, when he's in phase 3. So it will be an OPD based rehab. We will prefer oxygen. We'll require oxygen only during exercise, and we'll conduct PR according to the FIT principle. When this patient will go in phase 4, that is, he has to do everything at home, manage at home. So we'll give him a home program and self-management program. O2 requirement progressively is going to increase. We'll like train him for that, get ready, make the patient ready to accept it that his O2 requirement is going to increase. And then we'll focus only on breathing exercise, functional training, and secretion management. Further, if patient debilitates more, so he'll go into palliative care, then we'll continue his O2 requirements, and then we are going to perform only basic things, that is passive range of motion. So what is passive range of motions? The patient actively independently does nothing. It is we who do the range of motion exercises for him in bed. So this we basically do to maintain the muscle and to prevent DVTs. Breathing exercises, if patient can do it, chest PT to remove the secretions, and mobility, how much ever is possible for the patient to prevent bed sores and maintain the lungs, we will do mobility as possible. Any questions?
There's none in the chat. Anybody wants to ask a question? Carry on.
Okay, can we change? I guess we're done. Thank you. Any questions now? Like overall?
Yes, Dr.
Yes,
Subala.
Would starting pulmonary rehab early in the course of diseases help in the acceptance and management as the disease progresses, rather than wait for it when the condition advances?
Yes,
So
yes,
just
definitely.
like palliative care, I'll give it over to the two of you. Just like palliative care, ma'am, earlier integration of rehab, just like how you have patients with a stroke and you have patients with a fracture, when you before you send them home itself, you start involving the physiotherapist, give you for the range of movements so that the muscle rebuilds, etc. Similarly, when we diagnose a patient to have COPD, interstitial lung disease, etc., we encourage them to first be active in the sense that they're already on inhalers, they have a good lung function. We tell them not to lead a sedentary life, because for any patient, more so for the respiratory patients, the lung stamina is good when you're exercising. So simple brisk walk or cycling, badminton, whatever activity is important. Once their lung function starts declining, that is when we suggest rehab, because now they need supervised exercise to be done. So sometimes they might be desaturating, sometimes they might be doing the wrong exercises. For example, in interstitial lung disease patients with honeycombing, I don't know if you've heard that word, honeycombing, which is seen as a result of fibrosis. We avoid these patients to do forcible expiration like Kapalbhati, because then your honeycomb can rupture and give rise to pneumothorax. So when we realize that the patient is slowly becoming more dependent on his activities of daily living, or when there's a decline in the lung function, the earlier you refer to pulmonary rehab, the better it is always. And it also motivates the patient by seeing other patients. So essentially, like palliative care, the results are earlier you do, the better it is. If you search pulmonary rehab, there has been a lot of research done in COPD and showed benefits. Interstitial lung disease, there's not so much robust publication. However, patients we have seen with ILD also doing regular physiotherapy actually stay out of hospitals more, their immunity is more, their endorphins are released, so they are more happy, and therefore it is easier for them to focus on their quality of life. So I hope that answers your question. There's one
Yes,
more.
it does. Thank you.
Thank you. And Dr. Vidya, what did you want to ask about orthostatic exercises? Do you want to unmute and ask? Dr. Vidya?
Ma'am,
Yeah.
yes, ma'am. So I just wanted to ask, what is the scope of orthostatic exercise in case of a cardiac patient? That is what is prescribed also in by the cardiac physician itself. So if she could enlighten us on that, would be a lot of use.
Either of you.
Okay, so by orthostatic exercises, you mean patients who have postural hypotension, right? Okay.
Yes,
Yeah.
exactly.
So what we do in postural hypotension is gradual mobilization.
See, like here we are trying to get their functions to normalcy. For example, just micturating may put them into hypovolemic shock, something like that. The mind postural changes would put them in a very unacceptable outcomes. So in these patients, what are the exercises you can ask them to do?
Yeah, so firstly, if this is a condition, we do it in a very like a supervised manner. So there's a physiotherapist, there's a physician who has told us to do these exercises. So first we'll check the vitals, right? Before starting the exercise, we'll check the vitals. So if the patient is on bed, so gradually make him sit on the edge of the bed. Again, see the vitals. Again, see if the patient is comfortable. Again, see his RP on box scale. Okay. If patient is comfortable in sitting, then we progress to standing. Then we progress to walking. Is
So,
are you satisfied with my answer?
Yeah. No. I understood this.
Yeah.
That is what we are also trying to do. But if there is any much better thing, like for example, uh, in the just recline position, can he do few exercises in order to?
Yeah. We can do. So in reclining position, we do basic bed mobility exercise. That is ankle toe movements, bending your knee, straightening your knee, then moving your legs in and out. You can do breathing exercises in your reclining positions.
Okay, thank you.
Mhm.
another thing here, there's a question here for patients with decompensated heart failure in whom activities increases the demand, do they still need exercises? So I think the fundamental here about rehab is everybody needs exercise. Now you need to individualize the treatment depending upon the patient's condition. For example, my 90-year-old mother-in-law has a ischemic heart disease and one episode of cardiac failure. One cardiologist told her, now use the wheelchair only. She was so mentally depressed with the idea of just sitting in the wheelchair and moving from room to room. When we met another cardiologist, that person said, do simple exercises. Walk five steps a day, walk 10 steps the next week, walk 15, and slowly improve your endurance and stamina. See, for example, my one example I give everybody, all the patients, please physiotherapists, correct me if I'm wrong. Tomorrow, if I have to run the marathon, I cannot run the marathon in one day, 21 kilometers or 42 kilometers. I have to train my so-called fit body to run the marathon. So for the cardiac patient and for the COPD patient, going to the toilet is his marathon. Going to the garden is his marathon. He has to train for it. So first day, he might feel breathless in 2 steps. Therefore, you keep doing the 2 steps every day. The answer to that is not to do the 2 steps. Because the mantra is, if you don't use it, you lose it. So the more you use, every day you walk 2 steps, then next week you walk 4 steps. That is all the carrot you have to show him. That to use the toilet independently, just do this much. So initially, they might not even be able to walk 2 steps. So the first thing we do is let the patient stand, sit with the legs hitting the floor. Then next week, he can spend just getting up from the bed and sitting down on the bed. Then chair, then walk. So it is slowly. Everybody needs exercise, because exercise is not just for activities of daily living. It is for mental well-being. It is for independence, dignity, respect, the fact that, even with the heart problem, you're able to do little things. So that is the reason that we need to focus. And I think even in our medical training, the focus is for physiotherapy is only post-neuro, post-stroke. We need to realize this importance of any kind of rehab and exercise for example, a patient has gone to ICU for any other reason and come out of it. He's completely deconditioned. He definitely needs to focus on the exercises. So very important to, whatever that patient is able to do. You don't have to tell him, okay, tomorrow you have to walk 1 hour. No, it has to start low, go slow. Again, mantra of palliative care, which we all do. Anything you want to add before I take the next question?
Yeah, I would just like to add, because there are so many things about cardio coming in. So pulmonary rehab and cardiac rehabilitation are two different things. First of all,
Yes.
when we do a cardiac rehab, there's a different setup altogether for cardiac rehab. So whenever we do cardiac rehab, continuous ECG monitoring is very important. So if you all see cardiac rehab centers, whenever the patient exercises, they have this 6-lead ECG or 12-lead ECG going on when they exercise. And compulsory, the physiotherapist is there, the cardiac physician is also there, has to be there whenever we do a cardiac rehabilitation. Whereas pulmonary rehabilitation, it has you don't need an ECG for it continuously. You just need a pulse oximeter.
So that's the next thing that Dr. Deepak has asked. Is there any inexpensive apparatus or equipments which we can buy and give patients, which they can learn to use and do it at home itself, which will help? So actually, Dr. Deepak, like she said, you need pulse oximeters to know how much the oxygen is while exercising. Therefore, you need an oxygen concentrator if the oxygen levels are falling. Other than that, you only need to tell the patient, you have to teach the patient breathing exercises for which he needs no tool. Then you need some exercise resistant bands. You can ask the patient to increase the frequency and distance of his walking as a part of the aerobic exercises. So you really don't need much. What we need here is all of us to be sensitized, because like the observation Dr. Subbalakshmi has made, that despite all the money, even in multi-speciality hospitals, pulmonary rehabs dedicated are few. Even in Bombay, there are few. And the referrals to them also are few. And that is what is sad. We need to increase that, the awareness that it is as important as inhalers, as oxygen, as NIV, as counseling. Rehab is extremely important. Also, before I go to the next question, there was a question earlier about please demonstrate T and Y stretch again. So I request one of you to do it and one of you to like put the camera on the other person.
Okay, I'll do it. You will explain. Okay. So basically, first you will have to lie supine, like prone on your bed. Okay. So this is my T stretch. So my hands are in a T. Understood? And I just have to take them behind. So if you all can do it with me, you will feel that your pectorals are stretching and your scapular muscles are strengthening, because the scapular muscles are one which are contracting. Okay. And this is your Y stretch. So it's in a shape of a Y, and you again do that. So
the T is that your two arms and your body minus the head. And the
yes.
Y is the two arms and your body minus the head. That is the
So
stretch when you lie down on the back.
So this is for your pectoralis minor. If you all just remember our anatomy, our pectoral minor fibers are horizontal, whereas your pectoralis major fibers are diagonal. Okay. So this is your TNY stretch.
Yeah, thanks. Another point and observation by Dr. Rajeshri is that many hospitals in our country are focusing on pharmacological management. Sadly, yes. From patient's point of view, it is easy to follow medicines and leave exercises. For me also, it's easy to pop in a pill rather than say go and do 40 minutes cardio and 40 minutes in the evening walk. Hence, strong reinforcement of the community is needed. Yes, it is also a part of our training, ma'am. And like I said, between you and, I mean, for me at least, I push myself to exercise now because I've seen the benefits, but it is still that initial 10 minutes in the morning is I shall do it later, get up half an hour later. But once you see the benefits of it, it really does make a difference for even healthy individuals. How can we effectively use resistant bands in elderly whose muscles are on the lower side?
Yeah, so for them, resistance training is not only in a stretching bands. You can use your daily things in your house also, like a half kilo, like a half kg, half liter bottle, or a half kg, whatever grocery you get, half kg, 250. You can start with the lowest weight possible.
Comfortable weight.
You can also use your backpack and then exercise.
Right. So that is what we tell most of the patients, that pulmonary rehab is not expensive. It is just your
Can be
will.
done at anywhere, anytime.
I would just request all you doctors here, how, like, in India, it's a mentality. Like, medicines are very important. Physiotherapy can wait. Like, we can exercise after it. How medicines you all take on time, 9 o'clock, 12 o'clock, that mentality should come for physiotherapy also. Like, it has to be done on this time.
And I think a lot has to be done with the fact that the doctor puts a pressure of how important it is.
Yes.
But tell me something as a continuation of Dr. Deepak's question. When you use resistant bands, what are the exercises you do?
Yeah, so you can do elbow flexion.
Yeah.
Elbow, all your muscles can be strengthened by a resistant band. There are different positions for it. How you do it?
So can you demonstrate a few? For example, sometimes I tell my patients while watching TV, just sit and do some flexing exercises, then do some stretching exercise. So what is it that you all can tell? I mean, can you demonstrate? Also, there's another question to follow up that maybe you can do that as demonstration is for COPD. Can you say which exercise? Exercise 1, 2, 3. What is important so that at least the patient can get bare minimum?
Okay, as you know, COPD is an obstructive condition, right? So what is available in your house? A balloon. You can just ask them to blow. But what patients do while blowing is this. This is not helping you. This is just throwing out your air in your dead space. They have to do prolonged expiration, which has to be slow. It has to be.
So tell us about incentive spirometry. There was a question on that also.
I guess all of your love and
do that. Do we need what is the significance? Yeah, good. I'm glad the answer is in no.
Everyone feels that respiratory physiotherapy is just about incentive spirometer. Most of the times you are just damaging your patient by giving inspiratory spirometer. Like, for example, in pneumothorax, Inspiratory spirometer is causing a lot of harm. In COPD, inspiratory spirometer is just trapping all the carbon dioxide more and more.
So there is less role of incentive spirometry in patients with advanced lung. Where it helps is post-op patients. If you've had a patient with a gastric surgery, if you've had a patient with a thoracic surgery and your patient is in the bed, there is a lot of lung atelectasis. It's a healthy lung. That lung you can get back to normalcy with incentive spirometry. For a sick lung, it's not advisable to do incentive. Instead, like she said, breathing exercises with prolonged expiration. Yes. What else can we do?
You can do inspiratory holds.
You
That can help.
In ILD, especially most of the people think inspiratory spirometer is just put it in your mouth and just take in air as fast and as forcefully as possible. It is wrong. It is just increasing your work of breathing. If you see the new incentive spirometer which has come, it has a side marking, a smiley face, like extreme ends of the smiley faces are sad smiley faces, but the middle one is a happy smiley face. So you have to do it slowly. That is what is going to help reduce your work of breathing. When you do it forcefully, it is only dead space ventilation that is happening. The actual diffusion is not happening. For example, in ILD, what is affected? Diffusion is affected. So you have to give your lung that time so that healthy air is diffused. So you have to do inspiratory holds. Like whenever you suck the air in through your incentive spirometer, you have to hold that air. Then only your oxygen saturation is going to increase. But if you're just doing forceful inspiration, it is increasing your work of breathing, and further it is reducing your oxygen saturation on the oximeter. So how to use the incentive spirometer is very important.
You were
In
also
C-
going to demonstrate some exercises, Rasika.
Yeah, for the TheraBand, right?
Yeah, for
There
any,
is-
which exercise should us, so for example, if I'm a COPD patient, okay, I'm on inhalers, I have now started having difficulty in going to the bathroom, etc. I'm still not 6-minute walk test, I'm not desaturating, but I'm breathless on minimum exertion, say 10 steps, effort tolerance is 10 to 15 steps. What are the exercises you will tell me to do?
Okay, so whenever you're doing your ADLs, you have to keep on blowing. Like the blowing exercise is must for you.
So it's a pursed lip breathing.
Yeah, the pursed
And
lip breathing.
the idea of the pursed lip is to create a pressure difference between your airways and the mouth, so that you prevent collapse of the small alveoli, and all your alveoli take part in respiration.
Yeah.
So by causing a pressure gradient, like tell your patients to, while they do walking, while they are going to the toilet, this creates a pressure gradient, so all your alveoli are recruited in respiration. So that is the first thing you will tell them is pursed lip breathing. Then
Your breathing exercises, again focusing more on the expiration part. Okay, walking gradual. So according to ASVPR, a COPD patient should walk 30 to 45 minutes in a day, but that has to be gradual. So initially start with 3 minutes. Even if you're not, like, if you're not comfortable on 3 minutes, go down to 2 minutes. Progress gradually so that you have to increase the length of your walk. Initially we'll work on your endurance and then on your intensity. So you start with, if you start with 3 minutes, so according to 30 minutes you will have to walk 10 times a day. Then you progress, after like 4 days you progress to 5 minutes, so it will further reduce to 6 times a day. This is how we are going to train. Then you focus on your muscles. So in any respiratory conditions, your quadriceps muscles, according to research, are the ones who are worstly affected. That is basically because of deconditioning. Because your patient walks less, leads a sedentary lifestyle, quadriceps are the first one to go. You strengthen your quadriceps, you strengthen your upper limb muscles, because they are your accessory muscles for respiration, right? This is how we'll go. So
okay. The other question here is, how can rehab help in clearing secretions?
yeah, so in rehab we teach something which is ACT, that is airway clearance technique. So there is a there's an airway clearance technique which we do, in which there are 3 to 4 steps. So first is your diaphragmatic breathing. So you sit in a reclining chair. Your hands, can you all see me? Yo, okay. So your hands should be on your abdomen, right? So you breathe in slowly through your nose. And then you blow out through your mouth. This is your diaphragmatic breathing. So this has to be done 10 times. Then is your thoracic mobility. So in that, can I get up? So in that, your hands should be down. So as you breathe in, simultaneously you have to take your hands up. So breathe in. And then blow out. This has to be done for 10 times. And then you have to cough out or huff. This helps to mobilize your secretions, and then you can cough it out. So for this, you are dependent on no one, neither on chest PT. So our main aim is to make your patient independent, self-management of symptoms. That is the main thing. So I request like all of patients who can do things actively, can do breathing, don't make them dependent on chest PT, because it's not going to help in the long run. How much ever the patient is independent, that is going to boost their morale.
Also, in some conditions like bronchiectasis, etc., we teach them postural drainage, which means we tell them some. So if you imagine the lung, the patient is standing like this. Suppose the right part of the bottom part of the lung is affected, we tell them to lie on the left lateral so that everything rooms by gravity. Similarly, the other way. Similarly, if the patient has apical problem, then we tell him to lie down in 45 degrees because that's how the angles drain. So postural drain. So depending on the condition, if it's bronchiectasis where the airways are dilated, that is where we do postural drainage. Obviously, hydration, nebulization, all this helps to thin the mucus. And then we tell the patient to do these procedures. But in patients like asthma, in patients with COPD, they also have increased secretions, and these techniques help, like to clear, to produce that vibration sound so that it pushes the secretions towards the mouth. As it is, you must remember that even God is built the respiratory tract in such a way that the cilia beat 1,000 beats per minute towards the upper airway, so that constantly the lung is clearing secretions, small bugs, everything towards the upper airway, so that once it comes here, it's easy for you and me to cough out. So we just need to facilitate that by doing these maneuvers. Another important question. Yeah, you want to say something? Sorry, tell me. Go ahead, Rasika.
One more thing I would just like to add, ma'am, there are devices also, like which we showed, the positive end expiratory pressure devices like a flutter. They are like designed in such a way that if you blow in that, they'll produce vibrations which will go in your respiratory tract, mobilize those secretions, and help in coughing. So even you all can use
Is that something
also.
like a pulmonary flute? What is a pulmonary flute?
Pulmonary flute is a different thing, ma'am.
Yeah. What is it? Somebody has asked.
Okay, so pulmonary flute is basically used in obstructive diseases to help the trapped air to come out. Like I have seen we have rehab centers in Mumbai which are using it as an additional activity in rehab, so that even the patients enjoy it and they do it frequently. So in COPD, where there is air trapping, you use the fluid because that needs prolonged blowing out.
So Dr. Subbalakshmi has said that a patient found it great relief in clearing secretions. So if air is also going to get released, maybe even secretions will help. Correct?
Yeah.
Okay, there's another interesting question from Deepak. What if a patient who can't walk is wheelchair bound? What is the kind of pulmonary with COPD?
Okay, so for them, a patient who is wheelchair bound will focus more on strengthening. That is a way we'll condition his muscles, and breathing exercise even a wheelchair bound patient can do. So for this, from the strength point of view, you can do strength training on a wheelchair.
And another important thing for for airway diseases, like Rasika has been saying, all your accessory muscles use the shoulder as your fulcrum. So you need to keep upper limb really strong. So you can do all your exercises with the upper limb so that he breathes better. And how can you have aerobic exercises for the upper limb? Is it some ball?
We have. So we have something called as boxing.
Yeah.
Then we have something as in and out.
You
Okay.
have a hand cycle.
Hand cycle we have.
Right. So like you cycle
You
with the
can
leg,
do a
cycle
sit
with
to
the hand.
stand. Yes,
Yeah.
you can do a sit to stand transfer. If he cannot walk, he can at least stand.
Yeah, and many hospitals have a portable cycle also. So even a bed-bound patient on the bed can do cycling.
Understood. What about swimming?
Swimming is
is
a very
also
good
very
aerobic form of aerobic exercise. Should be done by pulmonary, like patients with pulmonary condition, but supervised.
Yeah.
Like when as we progress to phase 4, we tell them like this is your target heart rate. Like we designed a target, like we tell them this is your target heart rate. You have to exercise within this. So even when you're swimming, you can pause and just check your heart rate and continue.
Okay. So fine. So this is you're saying about, you have told them about breathing. You have told them about the aerobic exercises, the benefits of that. You have told them about the muscle training. And then you've also told them about the counseling as well as the nutrition. So it's again a holistic approach so that patients know what kind of food to eat. They also share their issues at home, that I have a problem with this, and it basically addresses and motivates them to complete their pulmonary rehab program. Now, I also want to ask you one, since we have been doing pulmonary rehab at Bhatia, with any one particular group of patients or even one particular patient, what have you seen? Can you describe the clinical journey of a patient through rehab along with the pulmonologist?
Yes. So at Bhatia Hospital, like most of the patients are COPD, ILD, which are referred to us. So we have seen patients who have come on oxygen and then they have rehabbed with us, and then they don't need oxygen now. Like they need oxygen only if the exercise or the activity they are doing is very strenuous. So we have seen patients coming down from oxygen. They don't require oxygen
What are
support.
patient feedbacks? Can you share?
Our patients' feedbacks, like we have them, but we have not actually added them here. So most of our patients are like, they are in contact with us. They have a positive feedback about the rehab and they are very happy, and they, in fact, there are patients who suggest it to another patient, like you do
We
it,
get
it
lot
is
of references.
yeah, we get a lot of references through our patients also.
Some
So
patients also
can you quote a couple of things that patients say that we can do this, or how they have, how does it translate to the patient's quality of life?
So most, like I had a patient who wanted to, like, after 2 years her son was going to get married, and she was in case of ILD, and she just had one hope that she didn't want to go on a wheelchair and she didn't want to go with her oxygen on. So after she completed her rehab, she did whatever was supposed to be done at home, and she just shared her pictures, like her pictures from her son's wedding. See, I don't require oxygen now. I can like do everything, whatever is necessary. So for them, all the small moments are very important.
It does resonate with what we want for our palliative care patients, that pulmonary rehab can actually contribute to. So I think even if the patient is like advanced lung conditions, if he's able to kind of sit up and eat, or able to go to the even bedside commode, not do everything on the bed. Those are the small goals that we can actually achieve for our patients. And I think the best part from what I have learned in my experience with physiotherapists is they really get to the level of the patient. I have seen my own father who used to wait for his physiotherapist because she used to come one refreshing face from outside. She used to talk about the weather and talk about the crowd in the train or something like that, to just have a topic of discussion, which is outside what is constantly happening in the houses. It's something that motivates them to the exercise might be only 30 minutes, the chat might be 30 minutes, but I think the chat also helps in the social interaction of these patients. So I think I cannot emphasize more how important it is to refer all your patients to some kind of exercise. It might not be structured pulmonary rehab for patients with advanced lung, but suppose a patient of cancer or suppose a patient, and just ask them to do some activity, even if it is trying to go and make one sabji or trying to go and, sit with in the park when the grandson is playing. These are small things, I think, that really help in overall rehabilitation of our patients. Anything else you would like to both add or something? I don't think there are any more questions, but there's one. How can we help a patient of COPD with bronchiectasis with neuropathy? And what kind of help would you want? To make him mobile? So here the targets are multiple, because you first need to help him clear his secretions, then you help him to breathe better, and neuropathy means peripheral neuropathy or what? So can you please clarify yourself, Dr. Shubhra? Yes, group rehab really makes a difference. Another question is, when we talk about community-based palliative care service, can we think of training volunteers from the field in some very basic concepts of pulmonary rehab and exercise, by which way we can make a sustainable effort? Yes, of course we can. And I think this is what Cipla Foundation is trying to do. They are having physiotherapists as well as to reaching out to communities which cannot afford. I will send you the details of the Cipla Foundation. Cipla Foundation contacts. I'll just message them so that that will be beneficial. To continue that question, COPD with bronchiectasis and neuropathy, how do you want to help his COPD and breathlessness?
Dyspnea relieving positions. First, if the patient is like very bedbound, dyspnea relieving positions and breathlessness. Relaxing techniques.
So all the non-pharmacological relaxation techniques, breathing exercises, position, sometimes even I think relaxation like music, all what we use for non-pharmacological techniques of breathlessness we should. And with neuropathy, what did you mean? There's no question.
I think they were trying to ask about peripheral neuropathy or post-op in cases of post-MRM. Usually we end up patients having neuropathy. I think that was the
Sorry, what? Post what?
mastectomy, post-surgery.
Okay, fine. So that is also a lot to do with pain management. And here Shubhra has also asked for INH induced, which is actually reversible. Isoniazid induced peripheral neuropathy is reversible with pyridoxine. That's why we give pyridoxine with isoniazid for patients with TB. And so it's a reversible neuropathy, unlike neuropathy which is due to diabetes or other neurological conditions. So they are saying, for example, the the neuropathy which happens post mastectomy to patients in the upper limbs. So, I mean, I don't know whether that comes under the purview of pulmonary rehab, but it could be more. You want to add to that?
Yeah, so it doesn't come under pulmonary rehab, but there are techniques where, onco physiotherapy courses are there. And there are physiotherapists specially trained in onco rehab who do this. So you have generally after mastectomy and all, the hand is affected more. So there are techniques to reduce the swelling because the patient develops lymphedema. So you do shoulder movement exercises. You focus on range of motion exercises more to regain the lost range of motion.
Rajam, I must tell something with no
Yes.
doubt. I think this was the most effective session so far in the whole series, because I remember hearing to one session on CME on community-based pulmonary rehab 8 years back. That it was a real eye-opener for me from a very senior pulmonary medicine person, and exactly these people were discussing about take your grocery thing, take one bottle, small bottle, half kg, sit on a wheelchair, move your arms, do cycling. So that is a new world of information for me. So you brought in the right people. I mean, they were very confident in what they were telling, and they answered all the questions right and left. And yes, we did one program for physiotherapists, but then we realized that should be open for doctors and nurses. Again, in that group, discussions like these were happening, and we were facilitating, and we realized that we don't know anything about it. So this should be open to doctors and nurses. And as they mentioned, there were people working in onco rehab. One small session we did for pulmonary rehab, but same thing happened. Lot of questions. So I think I realized that this should be split into small session. Onco rehab one set, pulmonary rehab one set, and probably as someone was mentioned, we need a small handbook which people can carry in the community to show the volunteers,
We
something
can
very
even,
basic that
or
everyone can.
Sridevi, to be honest with you, in our next endeavor, we should probably have a live demo.
Yes,
Because there are
yes.
two of them. One can do the talk, one can do the exercise, and the camera can focus on the exercise, and there could be a commentary, because then you can also get an idea of what to tell your patients. I mean, at least starting to, at least you get to know what it is for your patients. Then you know when the patient comes in front of you, whether he or she can do it or not do it. So that is also
True.
a live demo also is important. But I think
Yes.
the takeaway messages from this session, I'm glad that you and Rajalakshmi insisted on having this, is one, that it is extremely important for all patients, not even patients, human beings, to exercise. So you don't have to fall ill to exercise. That is point number one. Two, when you have a patient, the necessity to exercise becomes even more. See, for example, very often we see pregnant people, oh, don't do this, don't do that. And we say pregnancy is not a disease. She's supposed to be doing everything. But similarly, if a disease incapacitates you, exercise is supposed to help you overcome that. So it's important that even all your patients, not just neuro and ortho, need rehab. Everybody needs rehab. A patient has come out of ICU for anything, he needs rehab to get back on his feet. And it could be emotional issues, psychological issues, physical. Very, very important to emphasize on rehab. Second thing, great benefits in research on pulmonary rehab for advanced lung diseases. It, like I have mentioned in the chat, it definitely reduces hospitalizations. Patients recover fast from hospitalizations. Immunity is good. Endorphins is good. Depression is less. And therefore, the deterioration is also less. So it really does make a difference. And third, if you do not have pulmonary rehab, at least call your regular physiotherapist, share the link that Rasika and Shruti will be sharing with us. Let them read it. It is not going to be alien to them. And see if you can incorporate that in your daily practice. I think that is most important. There are some comments on the chat. Yeah, a module.
All wonderful comments to both of them.
Yes, thank you
for
so
the
much.
excellent session.
Thank you so much. And please go back and ask your department head whether they will be happy to train the interested physios, in small batches online or on Zoom. It's only going to increase the value of our hospital. A module with demos. Yes, thank you, dears. There you go.
I think you both are in our radar now. you are stuck with us now, Raju. I remember when I told about rehab, Raja was very confident. Yes, I have two people from Bhatia. Don't worry about the pulmonary rehab. We'll do it in
Because
the end.
we do it regularly. We send our patients and they come back raving about the department and they do a great job. The pictures you saw were of the physio department at Bhatia. So there is a lot of room. There are lots of patients who go, patients who come every other day. So they do a lot of good work. So with that, yes, somebody's giving us shabashi. So you can take the bow, both of you. Thank you very much. It's nice to see the young generation, talk so well and confident. Ashutosh, did you want to say anything?
Yes, ma'am. In a palliative care on a home care basis, this session might be very useful because the cases of CA lungs and COPD, as a palliative care physician, we can also guide them and tell them some of the exercise on home care basis, because we know our patient are almost as a terminal ill patient, like almost end of life cases or any all the terminal. So
Yeah.
it's a very useful session for us for the home care base also, to tell them some sort of exercise with the medication. So it was very useful session.
Great.
And also new to know. Thank you, ma'am.
Thank you. Thank you so much. Thank you so much for all your comments and encouragement. And I guess with this, it's a goodbye for now. But I hope to see a lot of you in IAPCON 2023. I'm not sure. It is going to be held in Bangalore. And we do have a day's session on respiratory diseases. And after listening to them, it just occurred to me that maybe we should have a half-an-hour session on live demo during that conference. So let's see if we can incorporate that. But please look after yourselves. Thank you very much again, both of you.